Sinusitis or sinus infection. Sinusitis is a common illness of childhood and adolescence, and there are two common types of acute sinusitis. Those are viral and bacterial sinusitis. We classify sinusitis based on the duration as acute sinusitis if the duration of symptom is less than 13 days, and subacute if the duration of symptom is between 1 to 3 months, and chronic if the duration is longer than 3 months. Approximately 2% of viral upper respiratory tract infection in children are complicated by acute symptomatic bacterial sinusitis. The ethmoidal and the maxillary sinus are present at birth, but only the ethmoidal sinus are pneumatized at birth. The maxillary sinus are not pneumatized until 4 years of age. The sphenoidal sinus are present by 5 years of age, and the frontal sinus begin development at around 7 to 8 years of age, and they are not completely developed until adolescent. So, ethmoidal sinus are pneumatized at birth, then maxillary sinus around 4 years, sphenoidal sinus around 5 years, and the frontal sinus later. The ostia draining, the sinus are narrow, and they drain into the osteomeatal complex in the middle meatus. The paranasal sinus are normally sterile and maintained by the clearance of mucociliary clearance system. When we see the etiology of acute bacterial sinusitis, the common bacterial pathogens causing acute bacterial sinusitis include strep pneumonia, non-type Haemophilus influenza, and the Moraxella catarrhalis. Staph aureus and the other streptococci and anaerobes are uncommon cause of acute bacterial sinusitis in children. The commonly recovered etiology from chronic sinus disease include H. influenza, alpha and beta hemolytic streptococcus, Moraxella catarrhalis, and the strep pneumonia, and also other coagulous negative staph. When we see the predisposing condition for acute bacterial sinusitis, the most common ones are viral upper respiratory tract infection followed by allergic rhinitis and tobacco smoke exposure. Risk factors for chronic or recurrent sinus include immune deficiency, cystic fibrosis, ciliary dyskinesia, abnormalities of phagocyte function, gastroesophageal reflex, anatomic defects such as cleft palate and cleft lip, and other causes such as nasal polyp and nasal foreign bodies, including nasogastric tubes. Acute bacterial sinusitis typically follow a viral upper respiratory tract infection. Initially, the viral infection produces a viral rhinosinusitis. The nose blowing has been demonstrated to generate sufficient force to propel nasal secretion into the sinus cavities. Bacteria from the nasopharynx that enter the sinus are normally cleared readily, but during viral sinusitis, inflammation and edema can block sinus drainage and impair mucociliary clearance of bacteria. Children and adolescents with sinusitis can present with non-specific complaints, including nasal congestion, purulent nasal discharge, fever, and a cough. Less common symptoms include bad breath or halitosis, a decreased sense of smell, and periorbital edema. Additional symptoms include maxillary tooth discomfort and pain or pressure exacerbated by bending forward. Physical examination might reveal erythema and swelling of the nasal mucosa with purulent nasal discharge. Sinus tenderness might be detectable in adolescents and adults. And transillumination reveals an opaque sinus that transmits light poorly. Differentiating bacterial sinusitis from a cold might be difficult, but certain patterns suggestive of sinus have been identified. This includes persistence of nasal congestion, rhinorrhea, and a daytime cough for more than 10 days without improvement, severe symptoms of temperature more than 39 degrees Celsius with purulent nasal discharge for 3 days or longer, and worsening symptoms either by recurrence of symptoms after initial improvement or new symptoms of fever, nasal discharge, and daytime cough suggests acute bacterial sinusitis than that of rhinosinusitis of viral origin. When we see the diagnosis of acute bacterial sinusitis, the clinical diagnosis of acute bacterial sinusitis is based on history as we said above, such as persistent symptoms of upper respiratory tract infection for longer than 10 days without improvement, severe symptoms, and a purulent nasal discharge for 3-4 days, and the worsening of symptom after improvement or without improvement of upper respiratory tract infection suggests acute bacterial sinusitis. So we diagnose acute bacterial sinusitis based on history. Bacteria recover from maxillary sinus aspirates in 70% of children with such persistent or severe symptoms. Children with chronic sinusitis have a history of persistent respiratory symptoms, including cough, nasal discharge, nasal congestion lasting longer than 90 days. Sinus aspirate culture is the only accurate method of diagnosis, but it's not practical for routine use for immunocompetent patients. So we diagnose acute bacterial sinusitis based on history. When we see the treatment of acute bacterial sinusitis, the first line is amoxicillin, and for penicillin allergic patients, cefdinir, cefuroxime, cefdoxime, and cefexime can be given. Azithromycin and trimethoprim sulfametazole or cotrimoxazole are no longer indicated because of high prevalence of antibiotic resistance. For children with risk factors such as antibiotic treatment in the preceding 3 months, younger than 2 years, and failed to respond to amoxicillin within 72 hours, and also with severe sinusitis, treatment with high-dose amoxicillin clavulanate should be initiated. Ceftriaxone might be given IM or IV who are vomiting or who are at risk for poor compliance, and it should be followed by course of oral antibiotics once vomiting subsides. The appropriate duration of therapy for sinusitis should be a minimum of 10 days or 7 days after resolution of symptoms. When we see the complications, because of the close proximity of the paranasal sinuses to the brain and the eyes, serious orbital and or intracranial complications can result from acute bacterial sinusitis and progress rapidly. Orbital complications include periorbital cellulitis and more often orbital cellulitis. They are most often secondary to acute bacterial ethmoiditis. We differentiate preorbital cellulitis from orbital cellulitis based on their clinical presentation. In the case of orbital cellulitis, the orbit is protruded and bulged, and it is erythematous, whereas in the preorbital one, the orbit is fine, but only the preorbital tissue is involved. And the best way to differentiate preorbital cellulitis from orbital cellulitis is by imaging, such as CT scan. Intracranial complications can include epidural abscess, meningitis, cavernous sinus thrombosis, subdural empyema, and brain abscess. Other complications include osteomyelitis of the frontal bone, which is called petit puffy tumor, which is characterized by edema and swelling of the forehead. Regarding prevention of acute bacterial sinusitis, prevention is best accomplished by frequent hand washing and avoiding persons with colds. Because acute bacterial sinusitis can complicate influenza infection, prevention of influenza infection by yearly influenza vaccine will prevent some cases of complicating sinusitis. This is all about sinusitis. Thank you for listening.